Guys, it's Omar, your favorite neurointensivist, I hope. We're gonna do a few minutes on ICP, right? So let's go over the ICP waveform. I'm gonna give you a shrewd look at a brain. So if you think about the brain, right, these are the lateral ventricles, the EVD is coming in this way. All right, I'm gonna show you just sort of a crude way of how we think about ICP waveforms, how they work, right? So when you remember an ICP waveform, you see three peaks, right? And then it repeats again, okay? This is your P1, P2, P3, sorry. So how does your P1 form, right? So when you're thinking about the EVD, the pressure will come here. When your heart pumps, all of the blood in the body will shoot up to the brain, right, and cause an increase in pressure in the brain. So the pressure is then distributed through the vasculature and through the brain parenchyma, through the CSF, and hits the EVD, and you get that first bump, all right? Now the second wave, in really sort of simplistic forms, bounces back, right? Think of it as a rock, in a pond where you see that wave hitting back. So it'll bounce back, hit the parenchyma, right? The brain has the ability to absorb a little bit, and so it will take some of that energy, and then as that energy is reflected back, you get a lower P2, right? So that's why P1 is higher than P2. P3 is clinically insignificant. It's a closure of the aortic valve. We don't really worry about it. What I want you guys to worry about is P1 and P2, right? So it's not just about the ICP number itself. It's actually, when you're looking at your patient, you want to know about the waveform. Why? Because if I have a patient, right, who has some sort of large hemorrhage, okay? So now there's a mass in there. So there's very little room, right? The Monroe-Kelly doctrine tells us that the brain is an enclosed space based off of CSF, blood, and brain. It cannot hold more than that, and if it does, something needs to compensate, right? So what happens with the compensation is the brain tends to compensate as far as compresses. So the brain here is really tight because of this hemorrhage, right? So your your heart pumps, you get your initial wave to the EVD, you get your initial P1, okay? Now, that energy is hit back to the brain parenchyma throughout the vasculature. The brain is very tense. It's non-compliant at this point, so when you decrease compliance, you increase elastance, right? So think of this, more elastic at this point, so that second wave will actually be higher, right, than the first wave. Okay, so here P1, P2, my handwriting is like a real doctor's, right? So P2 greater than P1, this is a non-compliant brain. This is a big deal because this patient cannot take a joke, right? If a small change in volume happens, say perhaps this patient's hemorrhage increases, when you're thinking about the pressure volume scale, or the pressure volume curve, all right? When the P2 is higher than the P1, that means any small change in volume causes a very large change in pressure. Up here, this P1 is greater than P2. You're over here actually on this curve. So a small change in volume only causes a small change in pressure. So the patient is compliant here. Patient can take a joke. Here, patient cannot take a joke. All right? I'll take a eraser. Was how we did sort of interpret the ICP waveform. Very important that you guys not only look at the number, but you're also looking at that waveform, because you can say, hey, listen, that P2 is higher, my patient is a little sicker today, right? Or can't take a joke today. Now, you're gonna have issues with your EVDs. It's normal, right? You gotta figure out what's going on. So sometimes your waveform will look, so if we say a normal waveform is like this, sometimes your waveform will look diminished, right? So what are the causes of being diminished? Very easy actually. So one is obstruction, right? So it means the dampening of the waveform happens because perhaps there's blood within the tubing, limiting the pressure that the brain can generate through the fluid to the transducer, right? So an obstruction, that could be debris, that could be air, right? It could be kinking of the tube, right? So those are things you need to look for when you see a dampened waveform. Also, when you are perhaps have drained a lot of fluid, increased drainage, the amplitude of your waveform may be decreased compared to prior because the brain is now not as sort of rebounded, right? There's more room in the brain because you have now drained CSF, right? Another thing that's going to decrease the amplitude is a DHC, right? When you take the skull off, the brain doesn't have that thing bouncing against it, so the pressures are going to be much less pronounced. So it's very normal to have a depressed waveform in the unit, all right? And these are sort of the reasons what could cause them, all right? What if what if you start to see a very high waveform compared to your normal waveform? That can happen when there's actually increase in CSF, so there's too much CSF, so basically increase of pressure. This can be a warning sign that your patient's ICP is starting to increase, all right? Now, if your patient's waveform is like this, there's really two reasons. Again, it's debris, something's wrong, some sort of obstruction, whatever, or hopefully not, but death, right? So you should not have a waveform when you're brain dead, okay? So when you have doing a brain death exam and you have an ICP waveform and there's an actual waveform on there, the patient's not really passed away, right? Because you cannot have a waveform without brain function or brain flow. Now, sometimes when you have an EVD, very rarely you could have a negative number, right? We've seen that a few times. What are the causes for negative ICPs? So the most common cause is leveling, all right? So when you have something like a negative ICP, you're gonna come in, you're gonna examine first the patient, make sure the patient's not dead, right? Negative ICP means the patient's not doing well. But on a serious note, when you're seeing a negative ICP, you're gonna check your setup, right? You're gonna make sure there's nothing wrong with the tubing, there's no air or anything like that. But you're gonna make sure your patient's level, right? And you can't just use eyesight. I know everybody's gonna tell you as you guys are training, you cannot use eyesight to make sure it's level. You must use a carpenter's level or a laser level, whatever we have to do that, because it's been demonstrated to be very inaccurate just by your eyes. Okay, let me give you an example. So say if your patient's ICP is 2 normally, right? And you're going to zero it right at the level of the external auditory meatus, right, the tragus, in a supine version, and then if they're laying lateral, then it's going to be between the midline of the eyes. If you have a patient whose ICP is just like 2, right, and perhaps the drainage bag and the level is above perhaps the head, right? Maybe the patient is slumped down or something like that. At that point, you're going to have an abnormally low ICP. So it's probably going to be negative at that point, right? Because the baseline ICP is already pretty low, right? 2 or 3 or whatever. So you raise that up, your number on the screen is going to be negative. Now, if it's 19 or 20 normal ICP, then perhaps the number you're going to get is like 15 or something, like, depending on how far you go up, right? But that's an easy case scenario where you have a very low ICP patient, 2 or 3s, and then it's not leveled properly, and because it's higher than the from Raymond Monroe, you're going to get a negative ICP. All right, so 1 is leveling. All right, 2, over drainage can be a problem. All right, when you over drain the patient too much, the brain sort of shrinks in, and you get a negative number. The other thing that you'll see sometimes, we probably won't see most often, is like a sunken flap. All right, syndrome of Terfine. So where their actual external pressure is higher than the internal pressure In a decompression patient, these patients go comatose just because they have very low ICPs, and the way to cure them is actually to put them flat. All right, but I think for all practical purposes, really, looking at the actual EVD, the tubing, making sure it's level, is your transducer working right, make sure the plug is cored, all those sort of normal things you got to look at. Now, very rarely you can have air in a certain area, and as you're draining it, it can create a negative ICP that way too, but most commonly I'm going to think about really where's your patient's level, right? That's going to be the most common cause for negative ICPs. What else do we need to talk about? I'm going to give you guys is ICP crises. We're going to go through it very systematically so that you guys know what to do when you're having an ICP crisis in a patient. Obviously, when you're having an ICP crisis in a patient, first thing you're going to do is make sure, again, that's my thing, level it, make sure your EVD is level, make sure it's a good number, right? 2, head of bed, up, and patient has to be midline. Why the heck does patient have to be midline? Well, you have 2 jugular veins here, all right? Out of the jugular veins, one jugular vein drains 70% of your anterior blood flow, all right? So you don't know which one it is. It could be the left or the right. Now, let's say if this side is the right side, is your dominant jugular vein. If my neck is like this, I'm not compressing the jugular vein, and that increases cerebral blood volume, which then increases ICP. So that's why we keep our patient's head midline, right? There is a rhyme to the reason. All right, what else? So you have now called the physician, right? And the physician says, I'm on my way, or the APP, I'm on my way. What can you do in the meantime? You can hyperventilate the patient, right? So hyperventilate, what does that do? So as you increase your breathing, you expel more CO2. When you decrease the CO2 in your system, the brain says, hey, I don't need that much CO2 anymore. I'm doing fine. Let me vasoconstrict. So once I vasoconstrict, I decrease cerebral blood flow, I decrease ICP, okay? So another thing that you guys can do is obviously CSF drainage, right? If it's there. The next thing to do is sedation, right? So you increase sedation. What does sedation do to ICP crises? Well, what you're doing is trying to turn off the brain. The less the brain is working, the less metabolites it needs. That means the less blood flow it needs. So that means the less cerebral blood volume it needs, and that's how you get decreased ICPs. All right, so turning off the brain basically is telling the body, hey, listen, I don't need that much energy to my brain anymore. I'm relaxing, just calm down. All right, so that's really how sedation kind of works. Once the providers come to arrive, they're going to give you perhaps hypertonic saline or mannitol. There's 2 reasons how this works, right? Diuretic. It's an osmotic diuretic, so it's a high solute, so the water likes to go to high solute areas, so it's going to take it from the brain, put it in the vasculature, and you're going to pee it out. But that actually happens around 4 to 6 hours later after the drug is given, okay? Before that, actually what it does, it changes the rheology of the blood cell. So the blood cell becomes more and more malleable, so it's able to get into tinier vessels, right? And so now you're getting better oxygen delivery to the brain. The brain says, hey, I got good blood flow to the brain now. I can actually decrease my cerebral blood flow, and that will decrease cerebral blood volume. That decreases ICPs. All right, so after that, sedation's not working, hypertonic saline still not working. That's when we move into other things, such as paralytics, right? Paralyzing the body decreases all of the tension on the abdomen. The abdomen and your thorax actually create a lot of pressure on your CNS. And so by relaxing all of those muscles, it inhibits the pressure on the CNS system, and your ICPs tend to decline. Sometimes paralytics don't work. You can cool the patient. TTM. Again, what is TTM doing? Well, when you're cooling the brain down, you're turning the brain off. You're doing the same thing like sedation, but even more so, right? You're telling the brain, hey, listen, you don't need that much blood flow. Just turn off. After that, what happens? ICP comes down. All right, so after all of this, cooling, then the last really thing is a pentobarbital coma, right? We don't do this very often because these other measures tend to work, or the patient goes to the operating room. But if you tend to do a pentobarbital coma, right, it's the same thing again. You're basically essentially resetting the brain, turning it completely off, very little blood flow to the brain, decreasing ICPs. So these are sort of our tier therapies, very to use. Most important for you guys, right, is going to be this portion. A lot of this stuff you'll be able to make sure before the team arrives, so that the team arrives and you can move quickly to the next portions. And that's it, ICP crisis.